Today we are going to talk about actually two important topics, which is uh, one is usually neglect, and the other one, which is a very common symptom, but the management is usually uh, whatever be the cause of that symptom, the management is now restricted to only one medication. So today we have Dr. Baburaj with us, who is the professor and head of Department of Anesthesia at Government Medical College, Thrissur. He is also the nodal officer for palliative care at Government Medical College, Thrissur. He has been into palliative care for last more than uh, 15 years, and he has also worked with Pallium India for almost 2 years. Now he is trying to integrate palliative care into various specialties in Medical College Thrissur. So welcome, Baburaj, sir, and it's over to you.
Thank you. Am I audible? Sunil, am I audible?
Yes.
Okay. Good evening. Now, let us start with the symptom nausea and vomiting. It is a very common and as well a distressing symptom in palliative care. Let us learn the meaning of three terminologies: nausea, retching, and vomiting. Nausea is an unpleasant subjective sensation with a feeling of need to vomit. The act of vomiting doesn't happen there. There is a subjective sensation which is very unpleasant, and there are lot of autonomic symptoms like pallor, sweating, salivation, tachycardia, and so on. What is retching? Retching is the rhythmic spasmodic contractions of diaphragm and abdominal muscles, which actually facilitates regurgitation of the gastric contents into the esophagus. So here what happens is both the diaphragm and abdominal muscles undergo rhythmic and spasmodic contractions. Here also the vomiting doesn't happen. It just facilitates the regurgitation. And what is vomiting? Vomiting is the expulsion of gastric contents. How does it happen? It is by the forceful and sustained contraction of abdominal muscles and diaphragm. So this slide tells you about this vomiting. Vomiting is mediated through the central vomiting center, and you can see so many active things are happening. Starting from above, see there is a closure of glottis, the soft palate moving up, the lower esophageal sphincter, that is, and the lower part of esophagus is relaxed, the respiration stops, the somatosensory signals to the through the diaphragm will cause movement of diaphragm up and contraction of abdominal muscles, which literally squeeze the stomach. At the same time, antiperistalsis happen and everything is expelled through the mouth and ends up in the cascade of vomiting. So all these are mediated through the vomiting center. See, 20 to 30% of all patients with advanced cancer will have vomiting, and 70% will have vomiting.
I think your voice is broken.
He might have lost the internet.
Oh, okay.
Baburaj, sir. We lost him.
Yes, sir. I think he got disconnected.
Yeah, we can wait for 1 minute.
Okay, sir.
maybe what we can do till he joins back. If you have any questions, we can discuss that. Anyway, you have gone through various modules.
Sir, when we should stop writing laxative when the patient is on morphine? How many
Okay.
days?
Okay. So that's a very important question. And what you have to understand is opioids, the tolerance does not develop to constipation. That means as long as the patient is on opioid, it will continue to produce constipation. So you would not be able to stop opioids, laxatives, once the patient is on any opioids. And another important thing is that about 95% of patients on opioids will have constipation. That means almost all patients will have constipation. So you have to prescribe a stimulant laxative along with the opioid. That means an occasional patient might tell you that I have diarrhea because only 95% of patients will have constipation. So if somebody says diarrhea, then you have to confirm whether it is a secondary diarrhea. That means because of the impacted fecal matter and due to long-term constipation. Suppose the patient is taking opioids and he was not taking opioid laxatives regularly. They may have constipation, and this can cause the fecal matter to be hard, and it can impacted anywhere in the maybe large intestine or rectum. And what happens is the fecal matter which comes above this impacted stool that will get liquefied by the action of bacteria. And whenever the patient does some strenuous exercises like coughing, sneezing, or something like that, this liquid fecal matter sweeps past through the sides of the impacted fecal matter and will come out as liquid fecal matter. So the patient will tell you that it is diarrhea. But the importance is that this will be only a small quantity, like staining of the underbird, but this will be frequent. Patient will come to you and tell you that I have diarrhea. So you have to get a very good history about the amount of fecal matter, smell, and things like that, and also get history of constipation. If there is history of constipation along with frequent small quantity of loose stools, probably that might be impacted stools. So that so that's what you have to elicit. So in short, the for opioid-induced constipation, as there is no tolerance develops to constipation, you have to continue the laxatives as long as the patient is on opioid.
Sir, our faculty has rejoined.
Okay, Baburaj sir.
Hello.
Yeah. You can continue.
Now am I audible?
Yes, sir, you are audible.
Okay, just now. Okay, I think there is some problem with the network. Problem with the sharing also.
Baburaj sir, you can switch off your video because I think your bandwidth is very low.
Okay. Okay. It's, I will do one thing. I will leave a region.
Your voice is breaking. Sangeet, can you switch off the video of Baburaj sir and see whether he would be able to speak normally?
Okay, sir.
Can you speak, Baburaj sir?
Am I audible? Am I audible?
Yes.
Now
yes,
it's
sir.
audible.
Now my
I think you have to keep your microphone near to your mouth. Otherwise, it's very feeble.
Yeah.
Now it's okay.
Yeah. Now how is it?
Yeah,
But
it's
there's
good.
some problem with the screen sharing.
So I have give the
Like
permission.
see my
now.
screen. Can you see? I'm not able to see the screen.
Please open the PowerPoint in your laptop first, and then share the screen.
Yes. Yes. It is obstructing. Something which is not moving actually.
Like maybe because of the low bandwidth. If you can share with us, I can share from my end too.
Okay. Let me see. So you leave and rejoin, right?
Okay.
The problem is there. It is hung actually.
Okay.
So maybe we can take another question till that get settled. Anybody else?
So today's topic is nausea and vomiting. Any advice for nausea and vomiting due to raised intracranial tension? If the patient has brain mets and is presenting with intractable nausea and vomiting, any suggestions, sir?
Okay. So as you know, many malignancies, especially lung, breast, these can metastasize to the brain and can produce increased intracranial tension with headache, vomiting. So this is a problem. So what usually we need to do? There is a practice of mannitol, dexamethasone, all those things. But what you have to understand is, in case of malignancy, the blood-brain barrier, which will be usually infiltrated with malignancy. There will be some defects in the blood-brain barrier, and for mannitol to act properly, the blood-brain barrier should be intact, which is not in the case of malignancy. So, if it is due to malignancy, it would be better to give steroids, and the one which we usually give is dexamethasone, which is the preferred one in case of to reduce the increased intracranial tension.
So if you're giving mannitol, do we stop it after 2 or 3 days, like we do for other conditions, or do we continue for longer?
Yeah. Mannitol usually has to be stopped after 3 days because otherwise, rather than decreasing the intracranial tension, it can actually produce more intracranial tension because it then starts to increase the edema and water content in the brain.
So for such patients, for the headache, Morphine we do not want to advise because it can raise the ICT even more. So what would you suggest for analgesics for such patients?
So, um, uh, first of all, we will try with steroids, and maybe sometimes, usually the dose would be about 12 to 16 milligram per day, and usually that will give pain relief. But even though theoretically it is true that opioids can produce increased it can cause carbon dioxide retention. But practically, if the patient doesn't have pain relief alone with steroids, you can give opioids. So we usually give morphine. Better to avoid tramadol in such instances because tramadol has a tendency to reduce the seizure threshold, and any patient with metastasis to brain, they have a reduced seizure threshold. So it would be better to use strong opioids rather than tramadol or tapentadol.
Thank you, sir.
Sir, is there any role of uses of glycerin suspension in such patients? Because I've seen one of the palliative physician prescribing that. So I was very confused. That's it.
Usually, I think it doesn't have much role in case of increased intracranial tension, especially in acute situation. Acute situation, you need to give dexamethasone, and probably you may add a mannitol for 2 or 3 days if the vomiting headache does not come down with dexamethasone. And what you have to understand is sometimes some patients needs lifelong steroids because otherwise they will not be able to get a good quality of life. So you have to titrate and find out the optimum dose of steroids, dexamethasone, that can be used. You need not continue with the 12 or 16 milligram of dexamethasone. You can reduce it and come to a level where the patient doesn't have much symptoms, but at the same time the side effects are also less. So there will be some patients who need to be on steroids for long term.
Yes, sir, our faculty has joined. I will be sharing screen from our end.
Okay.
Is it visible, sir?
Yeah.
Am I audible now?
Yeah.
Am I audible? Am I audible?
Yes.
Okay. And next slide, please. Can I operate slide from my side?
No, sir. Since we are sharing,
Okay.
I can operate from my
Okay.
side.
Next slide. Next slide. Next one. Next one. Next one. Okay. Next. Okay, this is the incidence. Now let us learn about the neural pathways of nausea and vomiting. Now, what's the need to learn about these neural pathways? This is to find out the receptors in these neural pathways. And if you know about the receptors, you can select the antagonist, and by selecting the correct antagonist, you can block the pathway. That is the advantage of knowing about neural pathways. So there is something called chemoreceptor trigger zone, CTZ, and there is vomiting center. And there is a third one, which is actually an antiemetic one, medullary antiemetic tone, which actually prevents the nausea and vomiting. Next slide. Now, in the picture, you can see the vomiting center is in the floor of the fourth ventricle. You can also see the chemoreceptor trigger zone. You can see in the floor, first you see CTZ, and a little deeper, you can see the vomiting center. Next slide. So CTZ, it is located in the area positiva in the floor of the fourth ventricle. And the important point is that where there is no blood-brain barrier. Next slide. So that is why I am underlining it. So next slide. Where there is no blood-brain barrier. Next slide. The vomiting center. Vomiting center is in the medulla. It is actually a collection of neural pathways connecting CTZ to something called nucleus of tractus solitarius and also the reticular formation in the medulla oblongata. Next slide. And this is known as, the vomiting center is known as central pattern generator, because this is a center which actually uh, uh, controls the vomiting or regulates the vomiting. Next slide. So this act of vomiting is controlled by the vomiting center. I have already said so many mechanisms are acting, starting from the closure of soft palate to contraction of diaphragm and abdomen muscles and also the antiperistalsis. Next slide. Now, medullary antiemetic, as I said earlier, it is an encephalinergic pathway, is a hypothesized, which actually acts as an antiemetic one. Next slide. Now, this slide tells you the various areas which are connected with the nausea and vomiting. The first one is vomiting center. I said that is something which generates the act of vomiting or vomiting reflex. And the vomiting center is getting impulses from one, higher cortical centers. Second, the chemoreceptor triggers from which I already mentioned. The third, directly from the stomach and small intestine. And the fourth, labyrinth. So vomiting center is getting impulses from all these areas. And finally, it modulates the act of vomiting reflex. Next slide. Now, let us learn about receptors. Now, first is chemoreceptor zone, CTZ. Now, what are receptors in there? Next. So, there are two important receptors there, dopamine 2 and 5-HT3. Both are there in the CTZ. Next slide. In the vomiting center, you can see a lot of receptors like histamine, H1, acetylcholine, and 5-hydroxytryptamine. The previous one was 5-hydroxytryptamine 3, but here it's a little different. Next slide. Next slide. And in cerebral cortex, something concerned with cortical vomiting, and mechanoreceptors are acting when there is an increased ICP. Next slide. Now, in the vestibular system, again, there are two receptors, types of receptors. One is histamine 1 and acetylcholine. Next slide. Now, in the gut and serosal surfaces in the viscera, we can see a lot of serotonin, acetylcholine, and H1 receptors. Next slide. Now, the receptors you have learned are dopamine 2, which is seen in the CTZ. You can see serotonin in the CTZ as well in the gut. Acetylcholine and histamine are seen in the gut, and histamine receptors are also seen in vestibular area. And in the brain, the nausea and vomiting is mediated through GABA and mechanoreceptors. Next slide. Next slide. Now, so this slide tells you about the various areas and various receptors. CTZ, the main receptor is dopamine 2. Next slide. And what are the stimulants for the CTZ? Next slide. Morphine, digoxin, hypercalcemia, uremia. So all these will stimulate CTZ through dopamine 2 activation. Next slide. Cerebral cortex, I said there are GABA receptors as well as mechanoreceptors, and the stimulants are next, fear, anxiety, raised ICP. So this is commonly seen in patients who are attending the cancer centers for chemotherapy and all that. So usually in the preceding evening, they develop nausea, and this is called anticipatory nausea or cortical nausea, and it is mediated through the cerebral cortex. Next slide. Gut, I said there are histamine receptors, ACH as well, serotonin, and the stimulants are intestinal obstruction, gastric irritants, cytotoxic drugs, and radiation. Next. Vestibular nuclei having two types of receptors already I said, acetylcholine and H1, and the stimulants are movement and vertigo. Next. Now, vomiting center, it also contains some receptors like H1 and ACH. Next. You can see from all these areas like CTZ, cerebral cortex, gut, through the various receptors I mentioned, the vomiting center is stimulated, and next, vomiting center initiates next something called the vomiting reflex by sending the motor and sensory stimulations to upper GI, diaphragm, and abdominal muscles. So this is in short the various centers connected with vomiting and nausea and also the receptors. Next. Next. So this is actually the previous one was a pictorial one. So what's the remedy? How to manage nausea and vomiting? The remedy is very easy. You can block the receptors at various sites. Next. Okay, you can think about the antagonist to these receptors. Next. Next. Okay, you can think about dopamine 2 antagonist. Previous one. Dopamine 2 antagonist, 5-HT3 antagonist, ACH antagonist, and histamine antagonist. Next. Okay, now we learned about the various centers connected with nausea and vomiting. We learned about the various receptors, and we also learned about the antagonist against these receptors. Now, coming to history taking, the timing of symptoms is very important. Next.
Is it okay, sir? So your audio is breaking.
Baburaj sir, we are unable to hear you. Okay, I think we again lost him, but we can take other questions till he joins back.
So, we generally give steroids for various reasons to these patients, and then we are talking of vomiting. There might be a hematemesis or something. So, in that case, we might have to put a Ryle's tube. So, does that not increase the risk of a gastric perforation as such? Because the patient is already on steroids, and now he's vomiting, and might be a hematemesis or something.
So are there any surgeons in this group? Okay, anybody has any opinion regarding this question?
Regarding the Ryle's tube, I am I find it unlikely that the Ryle's tube as such is going to cause gastric perforation. I think that is very unlikely.
Okay.
And at least personally, I am unaware of seeing any such episode in, I think, maybe 10 years of practice, more
See,
than that.
the patient is, if he's on steroids, I think he's more prone to gastric ulceration.
You need not present it in full.
Okay. So actually the timing is very important because depending on timing, you can have a diagnosis, a different diagnosis, whether it is coming from the due to gastric stasis, or it is from the vestibular apparatus, or it is due to raised ACP, or it is a cortical one, or it is something like intestinal obstruction. Next. Okay, these histories are important. Food and fluid intake, drug, constipation, urine reflux, and also ask how does it affect the daily life. Next. And of course, all these things have to be examined. Look for hydration, any fever, any jaundice. Because in jaundice, the earliest symptom could be nausea and vomiting. Of course, optic examination will use a raised ICP. Of course, abdominal examination is mandatory, and fever is also very important because constipation could be a cause of nausea and vomiting. Next. Okay, and this is something which we commonly come across in palliative care, and there are so many investigations that have to be done. Of course, depending upon the like suppose
उसमें
you
है
get
क्या कि
the result of
ये
investigation.
मेंटालिटी जड़ कर जा
So if you think the results are going to improve the quality of life of the patient, I think you can do the investigation. Otherwise, there is no need to do the investigation. Next slide. Next. Of course, coming to management, again, there are non-pharmacological measures, pharmacological measures, like, cooking, smell to be avoided, attention to unpleasant odors, small attractive meals, and so on. Next. Okay. Instead of, and I always think about correctable factors, constipation, opioid rotation, electrolyte imbalance, infection, hypercalcemia, and so on. Next. Okay, pharmacological methods, I said, I always identify the pathway, identify the receptors, identify the antagonist, and identify the root cause.
So the most important thing is that we have to identify which pathway is the cause of vomiting, and then we need to block that receptors. So metoclopramide has main action on dopaminergic type 2 receptors, and 5-HT3 only in higher doses. So maybe more than 80 to 100 milligram, it has some action on 5-HT3 receptors. But as all of you know, it is a prokinetic agent as well. So it will increase the peristalsis in the intestine, so which will help in removing gastric stasis. And metoclopramide, as it crosses the blood-brain barrier, it can have sometimes some extrapyramidal reaction, but it is not very usual, but can occur with some patients. Yeah, next. So the next drug which commonly used in palliative care is haloperidol. So which is the strongest D2 blocker? So you can see D2 3+. In case of metoclopramide, it was D2 2+. And this is usually used for opioid-induced vomiting as well as for metabolic causes like hypercalcemia or uremia. All those situations, haloperidol would be helpful. And one of the important thing you have to understand is the doses required for treating nausea and vomiting is very, very small. 1.5 milligram to 1.5 milligram would be enough to treat nausea and vomiting, but to treat delirium, higher doses might be required. So that's the important difference between treating nausea and vomiting and delirium with haloperidol. Next. So ondansetron is one of the main medications which everybody prescribes now for whatever be the cause of vomiting. That's a usual thing which is prescribed now. But what you have to understand is it is a 5-HT3 antagonist. So it would be helpful to treat acute chemotherapy-induced vomiting or vomiting due to radiotherapy to abdomen and intestinal obstruction. And usually 4 to 8 milligram 8 hourly. Ondansetron can cause two important side effects, which I think many of the people are not aware. It can cause headache and constipation. We can see, or we are seeing many patients who are on ondansetron who comes to us with constipation. There are no laxatives prescribed for them. So it is very important to understand that ondansetron, even though it is useful in various situations, but it can cause constipation. So prescribe ondansetron only for indications that is useful with ondansetron. Next. So hyoscine butyl bromide, I know some of you might have used. It actually causes relaxation of the GI tract, but it is an anti-cholinergic agent. So you can see that it acts on acetylcholine and it reduces the movement of the intestine. It can be used subcutaneously as well as IV. And hyoscine is the drug of choice when the patient has total intestinal obstruction, when you have to paralyze the gut. It not only relaxes the intestine, but also it is an anti-secretory. So one of the causes of nausea and vomiting and abdominal pain in intestinal obstruction is fluid accumulation. So which will be reduced with acetylcholine. Next. So this is something which you can note. It would be pharmacologically nonsense to prescribe metoclopramide and acetylcholine, metoclopramide and buscopan, that is hyoscine butyl bromide together. Because metoclopramide is prokinetic, which acts on the 5-HT4 receptors in the intestine, and which increases the acetylcholine release and thereby increasing the peristalsis. But what happens in with hyoscine butyl bromide? It also acts on the same receptor, but it acts on the opposite way. It actually reduces the movement of the intestine. So don't prescribe metoclopramide and hyoscine butyl bromide together. Yeah, next. Cyclizine is actually not available for us, but this is very helpful in patients with raised intracranial pressure. Next. So domperidone. Domperidone does not cross blood-brain barrier, but it's also a prokinetic. So that's the difference between metoclopramide and domperidone. One crosses blood-brain barrier, the other doesn't cross the blood-brain barrier. Next. So dexamethasone is sometimes we can call it as a broad spectrum antiemetic, and it reduces the permeability of blood-brain barrier to chemicals. So that's how it reduces the nausea and vomiting. And we also discussed that it can reduce the intracranial pressure by reducing the peritumor edema. Next. And benzodiazepines, we talked about anticipatory nausea and vomiting, where the patient starts to have nausea and vomiting usually on the previous day of chemotherapy, or whenever they see or smell that is something related to chemotherapeutic agent. So that is anticipatory nausea and vomiting, and usually if you give good control of nausea and vomiting on the first cycle of chemotherapy itself, you should prevent or should minimize the occurrence of nausea and vomiting whenever the patient has first cycle of chemotherapy. Then the incidence of anticipatory nausea and vomiting is very less. That's what studies are saying. As well as sometimes some people prescribe benzodiazepines for treating anticipatory nausea and vomiting. And lorazepam is one of the common benzodiazepine which is used. Next. Levomethroxam is not available for us. Octreotide is another medication which can be used especially in patients with intestinal obstruction, which is again anti-secretory. Okay, next. So please keep it here. So I would like to ask, what is the drug of choice for opioid-induced nausea and vomiting? Anybody?
Metoclopramide.
Okay, metoclopramide,
Ondansetron?
not ondansetron. Ondansetron is 5-HT3 antagonist. Usually, it is the dopaminergic type 2 receptor blockers are used as a drug of choice. So either haloperidol or metoclopramide are the drug of choice for opioid-induced nausea and vomiting. Some people use small doses of haloperidol, like I said earlier, 0.5 milligram. But many people use metoclopramide because it also acts on the GI tract, which can increase the peristalsis, and it can reduce the opioid-induced stasis of the intestine. What is the drug of choice for acute chemotherapy-induced nausea and vomiting?
That's
Domperidol.
Ondansetron.
ondansetron.
It is 5-HT3 antagonist, usually ondansetron, granisetron, and nowadays there are more costly medications like palanosatron and things like that. Renal failure? Renal failure, which pathway it causes vomiting?
CTZ?
Uremia,
Yeah, it is
uremia
usually,
because of uremia, the patient
yeah.
will get vomiting. So
Yeah.
5-HT3 would be better, or blockers will be the option.
Not really.
Metoclopramide.
It is usually the chemoreceptor, CTZ, where D2 receptors are more available. So D2 receptor blockers like the haloperidol are usually better for uremia-induced nausea and vomiting. Functional gastric stasis. You have to increase the peristalsis, isn't it?
Metoclopramide.
Metoclopramide.
Yeah. Raised intracranial pressure.
Dexamethasone.
Yeah, dexamethasone. Vestibular induced nausea and vomiting. It is again,
Cinnarizine. Cinnarizine.
yeah, Cinnarizine,
H1 ACH antagonist.
Stemetil, that is prochlorperazine, promethazine. Antihistaminergic would be more helpful. Cyclizine would have been better, but it is not available. Inoperable gastrointestinal obstruction. You can use various things, but
Octreotide.
yeah, octreotide or hyacinth butyl bromide. Yeah, next. Okay, next. Okay, is there any, do you want to ask anything else from nausea and vomiting?
Sir, about mannitol, it is not given. Mannitol is not to be given for decreasing cerebral edema.
Yeah, it can be given, but as I told you earlier, in malignancies, the preferred medication is dexamethasone, and that can be given continuously. But mannitol need to be stopped after 3 to 5 days maximum. So in malignancy, usually the drug of choice is dexamethasone, and mannitol can be added if there is no much relief with dexamethasone.
Dexone is to be given for how long? In
So
malignancy.
I think I answered this previously, but maybe you have joined later. So sometime you have to suppose the patient is having malignancy and patient is receiving the radiotherapy. Then you have to continue the dexamethasone even after chemotherapy and gradually decrease and stop. But sometime what happens is sometime no curative or palliative radiotherapy is possible, and in such instances, if with the dexamethasone, if the patient is getting relief, then you reduce the dose and find out an optimal dose which reduces the patient's symptoms, but that also doesn't produce much side effects. So you have to find out such a fine balance by titrating the dose of dexamethasone, and probably you need to continue the dexamethasone lifelong in some patients.
Thank you, sir. Thank you.
Anybody else?
So on a slightly related note, what about a patient who has intractable hiccups? What can we give for that, sir?
Okay. So first of all, 70 to 80% of the causes of hiccup are from GI tract itself. So usually this can be managed with proton pump inhibitors and prokinetics. But in some cases, if that is not getting relief, then you have to use baclofen. Baclofen is a good medication that can usually give a relief to hiccup. And even if that is not giving relief. So first of all, you have to find out why the patient has hiccup. So that is the first thing. Then identify and treat that thing. So that's where I talked about mainly these are things which comes from GI tract, maybe increased acidity or things like that. And sometimes it might be the liver metastasis, which can actually irritate the diaphragm and can cause hiccup. And in such instances, what will be your drug of choice?
Steroids, sir.
You can reduce the peritumor edema. That can actually reduce the hiccup. But if the hiccup becomes intractable, then baclofen, sometime sodium valproate might be used, gabapentin might be used, and even sometime midazolam, large doses, would be useful. So that's how intractable hiccups are treated.
Thank you, sir.
Anything else? So let's move on to constipation. So if any of you have any comments about constipation, please, can some of you talk about the important points in constipation? So let me ask you, what are the complications of constipation?
Intestinal obstruction,
Okay.
impaction
Not
of stool with can cause secondary intestinal obstruction in extreme cases. We can
okay.
miss that, so we should be careful for the most dreadful complication of constipation.
Okay. Yeah. So, does the patient has real intestinal obstruction, or is it due to patient having obstipation? That is absolute constipation. What are the complications?
Rectal fissures and sometimes rectal prolapse.
Okay. More common things.
Hepatic
What are the-
encephalopathy.
Sorry.
Hepatic encephalopathy.
No,
If the
more
patient has
common
liver
problems
failure.
if somebody has constipation. What are
Pain
the
and-
common problems?
Pain and delirium, sir.
Yeah, it can cause pain,
As well as
abdominal
delirium.
distension, and another important thing is delirium. Constipation, especially in elder people, can cause delirium as well as urinary retention. So, with if you miss the constipation, then that can cause a lot of things, which even may mimic that patient has severe problems. So, this is usually missed by the clinicians, and they will do all lot of investigations, including CT scan and MRI, but sometimes the cause might be constipation. If you relieve the constipation, then patient will be all right. So if any elderly presenting with delirium, please check whether he has constipation or not. So that much important. And many catheterizations might be avoidable because whenever we hear about urinary retention, we put the patient on continuous Foley's catheter. But if the patient has constipation, maybe we have to relieve the urinary retention by Naloxone catheterization single time. And if the patient has constipation, give enema and relieve the constipation. That will relieve the urinary retention.
UTI in children. Urinary tract infection.
Yeah, it can chronic constipation can actually cause urinary tract infections. Okay. So what are the causes of constipation?
Decreased fluid intake,
Mm,
fiber intake.
mm. Okay.
Certain drugs like morphine, most of the opioids.
Okay. What are the drugs which can cause constipation?
The opioids in general cause.
Yeah. Yeah. And any medications with anticholinergic properties. Okay. So tricyclic antidepressants like amitriptyline, imipramine, that can cause constipation. And we already talked about hyacinth butyl bromide, which is an anticholinergic. So there are many other groups, but these are a few medication which we commonly use in palliative care, which can produce constipation.
Intracranial space occupying lesion.
Okay, so you mean to say if there is an intracranial space occupying lesion, the patient might not feel the sensation of fullness of the rectum and thereby causing constipation.
Bedridden patient or non-ambulatory for a long time.
Yeah, that is one of the common conditions in which patient's abdominal musculature is very lax, and that will not aid with peristalsis. And sometimes patients with spinal cord injury, they might have lost the bowel sensation. So, yeah, those are few important causes of constipation. And as you know, the local problems like hemorrhoids, fissures, all those can cause constipation. And one another important thing is privacy, which we usually don't look into. Suppose a patient is admitted into a hospital. In a hospital ward, patient is bedridden, and usually what happens, especially in maybe government hospitals, there is no proper privacy. The patient is asked to pass motion in the bed itself. So there will be a screen on one side and nothing on the other side. The patient may not pass constipation because patient may not pass the bowel because privacy is very important, because our brain has to give order to relax the anal sphincter. Then only we will start passing motion. So that will not happen. Okay.
Inadequate fiber can also lead to this, means less of vegetables or fruits in the diet.
Okay. Yeah, there are a lot of things which can cause constipation, but what we need to understand is there are a few things which we usually avoided. Things like privacy, which is very important. and maybe drugs causing dehydration like um, furosemide. So those are few things which you need to look into. Otherwise, most of us will advise the patient to take a lot of water, increase the fiber content of the diet, etc., etc. So, what are the groups of medications that is used to treat constipation?
Stimulant laxatives.
Okay.
Then
Glycerin
drugs,
suppositories.
Okay.
drugs like polyethylene glycol.
Okay.
Lactulose,
Can
or
somebody
isabgol.
classify the laxatives?
Bulk laxatives,
Okay.
osmotic laxatives,
Okay.
Stimulant laxatives.
Okay. Yeah. Anything else?
Stool softness.
Okay. Yeah. So lubricant laxatives. So lubricant laxatives, the example is liquid paraffin. So it's a common practice to prescribe a brand name called Cramafin, isn't it? Cramafin Plus or Cramafin, which mainly contains a liquid paraffin along with other laxatives. But the main content is a liquid paraffin. So, which is a lubricant. It lubricates the fecal matter. That's all it is doing. Okay. Then we have bulk forming laxatives. And this is usually taken by elderly people. So, what are the examples of bulk forming laxatives?
Ispagula husk.
Yeah, Ispagula husk, methyl cellulose. So these are this comes in powder form, and which we will ask the patient to mix with water and immediately take it. But what happens if you don't take it immediately? Anybody knows?
This taste will be bad.
Yeah, maybe, but that's not what I am looking for. Anything else it can cause if you don't consume it immediately?
It will become bulky and difficult to swallow.
It actually becomes harder. Okay, the this powder will absorb all the water and becomes harder. So when you advise the patient to take bulk forming laxatives, you have to ask the patient to drink a lot of water. Otherwise, it can add to constipation. So bulk forming laxatives are actually contraindicated in patients using opioids. So never prescribe bulk forming laxatives who are on opioids. So it's also your responsibility to check whether the patient is taking any laxatives whenever you prescribe opioids. And if there is bulk forming laxatives, you have to stop it. So lubricant laxative, bulk forming laxative, then stimulant laxatives. So we know that the choice for opioid induced constipation is stimulant laxatives, and usually used one is bisacodyl, but sodium bicosulfate and senna is also used by some people, which are also stimulant laxatives. Then osmotic laxatives, lactulose and polyethylene glycol. Then some of you talked about stool softeners like docusate sodium. Okay. Then in addition to this, we have rectal laxatives like suppository and enema. Um, okay. Anything else you want to ask from constipation?
Is glycerin suppository helpful for patients in patients on morphine?
Glycerin suppository, what is the mechanism of action? What does glycerin do? Glycerin actually softens the stools. So if there is hard stools in the rectum, then glycerin can be used, which can actually softens the stool. Okay, and maybe next day you have to give some stimulant suppositories like bisacodyl, or even you can give any mass like sodium phosphate, which are stimulants.
The digital rectal evacuation.
Mm.
Uh,
Yeah.
That will also be of any use during constipation?
Okay. Yeah. It's very important that if the patient has constipation, uh, maybe for more days, then you have to do a rectal examination. And if you see that there is impacted stools lower down in the rectum, then you have to, or even if there is hard stools in the rectum, then patient will not be able to pass motion by themselves. So you have to remove it by using your fingers. So that's and then you have to give enema after removing the hard stool. So digital rectal evacuation is very important in patients with long-term constipation.
Thank you.
Can we combine two types of laxatives give multiple type of laxatives for patients?
Yeah, you can do that, but usually combined laxatives for opioid-induced constipation is you can combine the stimulant laxative along with lubricant laxative, that is liquid paraffin, or even you can combine it with um, os- osmotic laxatives like lactulose. Anything else? So, are you all progressing with the modules? Do you have any issues in accessing the modules, and how do you find it?
So sometimes I get stuck, means at the end, it doesn't show anything. But recently it has been far better.
Okay. So if you have any issues in accessing the modules, please send a message in the group. So we have our IT personals in the group. So they will solve your problems.
Okay, thank you.
Anybody is doing the modules from mobiles, or all of you are using laptops or desktop?
Right now, we need to access it on the computer. Would it be
Yeah.
possible to do it on the mobile or the tablet devices?
It is not very mobile friendly. That's the problem. But we are trying whether we can do that.
I have used it on mobile once or twice, sir. It is happening. Most of the time, I'm using laptop or desktop.
Okay.
Some once I used in mobile, like I had gone out, so I had to finish the module. So that time I used mobile. It did happen, but or in desktop view, I had to do it, sir.
Yeah. Yeah, mobile we can use, but it is not very mobile friendly. That's the problem. Okay, I think if there are no more questions, we can wind up for today. So actually, Dr. Baburaj was had some net issues. That's why he was unable to, or he went in between. But anyway, it's thank you everybody, and
Excuse me, sir.
request
Today,
you.
I think case presentation was there, no?
Was there any case presentation?
No, sir. We have not received any case presentation.
Sorry?
I was told to, I had submitted a case of GI
Okay, I
symptoms.
think we can present that patient story.
I had sent the PPT also.
Sangeet?
Yeah, just a minute, sir.
Because it is related to this topic, I was told today maybe we'll present. That's why
Okay,
since
okay.
we have
Yeah.
time,
Please go on.
it's a short case only.
Ma'am, have you sent it in the email or?
Yeah, I have sent on mail, sir.
Okay. Yes.
Shall I forward it once more?
Yeah, ma'am, that would be nice.
Yeah, just a moment. Kindly check, I have forwarded.
Yeah, got it, ma'am. Just a minute. Okay, ma'am, you can proceed.
Yeah. So good evening, everyone. This is Dr. Shilpa Apke. I'm professor of medicine in from Dharwad. I'll presenting a case, next slide please, of a 65 years old male patient with the diagnosis of CA pancreas adenocarcinoma. This patient had following complaints of reduced appetite, abdominal pain, constipation, black colored stool, and bilateral limb swelling These symptoms were since last 6 months. Please continue with the next slide, which was gradually progressive. For initial 3 months, he didn't take any opinion of any doctor, but since last 3 months, that is after 3 months of the symptomatology, with gradual progression of generalized weakness, severe backache, he consulted a local physician who advised him few investigations, out of which, after UHG abdomen, which was suggestive of pancreas malignancy, he was further advised CACT, which confirmed CA pancreas, head and tail with liver mets and renal calculi. So he was referred to local oncologist who advised radio and chemotherapy. But the relatives till then had not counseled the patient about what he was undergoing, what was his diagnosis. And there was a delay in actually starting the specific treatment. So after 1 month delay of diagnosing CA pancreas, he went to specific treatment. In this period of 1 month, he took herbal medications. Meantime, he was on morphine also, which was advised by the local initial physician. Morphine dose was 10 milligram BD for pain. So this time when he had presented to us after initiation of radiotherapy from the specific oncologist, he had developed constipation as laxatives were not co-advised. So after 6/15 radiation therapy, he also started losing appetite and he had literally stopped taking anything orally, and then RT feed was started. So gradually there was progression of the disease, no response to the radiation therapy, which was initially they had planned for radiation for backache with the meds. Depression condition was deteriorating. So from the oncology center, the patient was referred to us, that is at the tertiary care center. He had approached to us 3 months back with this history. Please continue. So when we received the patient 3 months back, on examination, patient was drowsy, arousable. He was not obeying commands. He was in encephalopathy with asterixis present. Bilateral gross edema was there. He was icteric. Though the vitals were stable, on systemic examination, his liver was palpable. It was tender. Ascites was present. CNS-wise, as I told, he was drowsy, arousable with flaps. Antibiotics were given, anti-NCAF measures were given. His albumin was low with edema. Human albumin was given for backache, severe backache. Buprenorphine patch was taken. That was his main complaint also. Metabolic derangements in the form of hyponatremia and hypokalemia were corrected. LFT was deranged in the range of 15 total bilirubin. Total counts were very high. So with this and the background of CA pancreas, ours been not having any malignancy center, onco center, we thought that we will send the patient refer back to onco center nearby. Meantime, when we go through the other aspects of the patient, psychologically the patient was depressed, relatives were in grief. Unfortunately, the patient had lost his wife in malignancy only 10 years back in the form of CA uterus, and the patient was not very economically stable. So medication point, we had given him phenterlin infusion, human albumin, anti-NCAF measures, and empirical antibiotics for him. What was the main concern when I went through this is supportive treatment and care was not initiated on the onset. Neither the relatives were taken into confidence. And I selected this case in view of the symptomatology pertaining to GI system, where it may attribute to the side effect of morphine with severe constipation. And only initially radiotherapy was advised. So later when we referred the patient, he had gone to proper medical oncologist instead of the local center where no much facilities were there, where he was initiated on chemotherapy. And just 2 days back, again, he has been admitted in our hospital with severe complications where the chemotherapy has also not worked up. And this time he has developed CNS mets also, and he is yet in a bad state. So to summarize, it was 3 months back, newly diagnosed CA pancreas, morphine-induced constipation, hepatic encephalopathy. Mostly a counseling part was absolutely not up to mark, neither to the patient. Patient himself came to know from somebody else, not from the doctor or from the relatives, as per I talked with the patient. Herbal treatment in between has added to the liver injury. And later, even when we had referred the patient to radio and chemo oncologist, I personally felt that there was no adequate counseling, and it was only particularly the malignancy was concentrated rather than full palliative care. So discussion points here for the selection of the patient was one, morphine-induced constipation, and the complications which he landed up was hepatic encephalopathy. Somewhere multidisciplinary care approach was missing in this. The patient should have been taken into confidence. Relatives could have been counseled in a better way so that they could have been stopped from going to quacks or taking some unwanted herbal medications, which initially when the bilirubin was 7, when the local physician was treating, it went to 12 before he approached the hospital. And that was gradually progressive. So this was a lack of initiation of palliative care also led the patient to this level. So also the approach of the patient to doctor was also late. Though the patient was symptomatic since 6 months, initial 3 months he neglected it, and then when it was full blown with meds in the spine with severe backache, he then approached the local physician. So I selected this case particularly for discussion of constipation and previously with reduced appetite manifestation. Thank you.
Yeah, here we have a patient who has an advanced malignancy, who is in hepatic encephalopathy, as well as on morphine without any laxatives. So it is very important that we should prescribe laxatives, that is stimulant laxatives, along with any opioids. Otherwise, it will add to constipation. So we already talked about the opioid-induced constipation, and how would you treat hepatic encephalopathy? Can anybody comment on this? What
We
would
will
you
give
do in
him
this case?
laxatives and see that his bowel movement is regular for prevention of accumulation of ammonia.
Anything? So what laxative would you use usually?
Lactulose I would like to prefer. I mean, lactulose would be a better option.
Yeah. So everybody knows how to treat hepatic encephalopathy. But I do not want to talk about the treatment of hepatic encephalopathy, but I would like you to bring to another point here. So whenever a patient is having an advanced malignancy, and if we feel that this patient is at the end of life, he has only a few days to live, then probably hepatic encephalopathy, we need not treat it actively because that will not make much difference. Otherwise, in a patient who has a few weeks to live, then we would treat hepatic encephalopathy. But withdrawing or withholding the treatment in such instances is ethically is okay, as well as even if we treat the hepatic encephalopathy, it is not going to cause much difference if the patient is at the end of life. So this is one point which I want you to think about.
So whether it is ethical to counsel the patient regarding stoppage, because 2 days back only when we personally talked, they wanted to take the patient home. Son wanted to take him home, but the daughter was very hopeful, and her question was, what are we going to go, and we can't see him suffer like that. So at this point, what would be your best suggestions, sir?
So what I would from what you are describing, I understand that there is some difference of opinion between the daughter and the son. So
Yes, sir.
I would call both of them and would understand what are their insight regarding the patient's present status. They might be at different levels of insight, and then bring them together to a common understanding that this patient has a very advanced malignancy. And then the next step, we have to find out why daughter told us that she did not want her mother to taken back to her home. So there may be many reasons. It might be she might be fearing that if she goes home, if something happens, we will not be able to manage. So we have to find out what's the main issues, what makes her to tell like that. So we have to find solutions for that. And if they are taking the patients home, we should have some anticipatory prescription. That means, suppose this patient is taken to home, you know that this patient can have these symptoms, may happen these symptoms. So when these symptoms occurs at home, we should prescribe something on an SOS basis if they goes to home, so that they can administer it. And we should also understand what is the if patient is in a condition and she is able to speak, then we should speak to the patient and understand what is her wish. Is it to go home, or is it to be remain at the hospital? That's also very important. Then if they are taking the patient home, we should I don't know whether it would be possible for you, but when we do that, we usually give phone number of our institution, which will work 24 hours. So if they are in doubt, or if they want to ask us anything, they can call us and speak to us 24 hours. In addition, we also have a telehealth, and they can actually make a video call, and we can see the patient. But even if there is no telehealth, if any of your doctors are willing, they can have a WhatsApp call and see the patient and do whatever is possible. So by this way, they would be more equipped to take the patient home. That's what I feel.
One more thing, sir. Oncologist, when it is in extreme stage, and when secondary meds are there everywhere, how about the role of vigorous radio plus chemotherapy, which they are advised to the patient?
So
palliative care would be a better option for this patient, no, sir?
So I would not be the right person to talk about this, because I do not know much about radiation and chemotherapy. So are there any oncologists in this group? So I think we would get their opinion. Who is from Cancer Care Center, Kottayam? Yeah.
Depending on the patient's general condition, he would have been advised palliative chemotherapy or radiation. I don't know why it was 15 fractions, but generally a smaller course of radiation for his spinal metastasis or the local disease could have been advised to control his pain. Also, morphine, if that was immediate release, it was only 10 mg, it was only twice a day, prescribed twice a day. So that is also inadequate for pain relief.
Okay.
Fine, sir. Nothing from my side. Thank you so much.
Okay. Okay. So I think we can, yeah. Are there somebody who want to speak? Okay, thank you, Dr. Shilpa, for presenting this patient story.
Thank you, sir. I
And
hope
making
it was scheduled or no, I don't know, but I was told that during this it was supposed to be presented.
yeah,
So I
yeah,
interrupt.
yeah, it's perfectly okay.
Thanks, sir. Thank you.
So, Dr. Ramesh, Dr. Ramesh, would you like to talk? Okay, but anyway, thank you, Dr. Silpa.
Yes, sir. Thank
So
you so
it
much.
gives us the message that whenever you prescribe opioids, you should also prescribe stimulant laxatives. Sangeet, that's all to you.
Okay, thank you, Dr. Sunil, for the wonderful topic. Thank you, Dr. Shilpa, for presenting the case presentation in a short period of time. Thank you, everyone, for participating as well. Thank you. Let's see you in the next session. Bye.
Thank you so much.